Assalamu alaikum. First of all, I would like to thank the Scientific Conference Committee for letting me to speak about my research about changes in axial length after trabeculotomy and combined phacoemulsification trabeculotomy in a sample of Iraqi glucomatous patient prepared by me, Dr. Ahmed Muhammad Kadhim and supervised by Assistant Professor Dr. Ahmed Majid Rashid. We have a quick review about some few points. Like glaucoma, it's an optic neuropathy that's consistent with excavation and undermining of the neural and connective tissue element of the optic disc, and by the eventual development of distinctive pattern of visual dysfunction. Trabeculotomy, as we know, is a surgical operation, fistulizing procedure, which lowers the intraocular pressure in patients with glaucoma. This is achieved by making a new pathway that allow aqueous humor to flow out from the anterior chamber through the surgical opening in the sclera and into the subconjunctival and subtenon space. Phacotrabeculotomy is a combined procedure in which both cataract extraction and glaucoma filtering surgery are performed in the same operative session. Phacotrabeculotomy can be performed through one incision or by separate incision. Axial length of the eye, the distance between the anterior center of the cornea and the posterior pole of the eye. In vivo, it's measured either by ultrasonography or by partial coherence interferometry, represent the distance between the anterior pole and the roof membrane. The axial length of the eye at birth is approximately 17 millimeter and reach approximately 24 millimeter in adulthood. The aim of the study to find if there is any change in the axial length that may be happened after trabeculotomy and combined phacotrab surgeries in glaucomatous patient. It's a prospective case series study that had been conducted after taking the patient agreement at Ibn al-Haytham Teaching Eye Hospital Glaucoma Department from the 1st of February 2016 to the 1st of August 2016 for 33 patients scheduled for trabeculotomy and 34 patients scheduled for combined phaco and trab surgery. The study documents age, gender, axial length of both groups preoperatively by non-touch technique. We use the Carl Zeiss IOL Master version 7.5. Preoperatively, then after 1 week and 6 weeks postoperatively with full ocular examination. Excluded from this study any patient that is diabetic, uveitic, neovascular glaucoma, history of trauma and complicated surgery like hypotonic choroidal effusion or detachment, maculopathy, suprachoroidal hemorrhage, endophthalmitis, blebitis, conjunctival recession, posterior capsule rupture and drop nucleus. As we know, the surgical procedure for trabeculotomy done by doing conjunctival incision, exposing the sclera, applying mitomycin, see partial thickness of the scleral flap, opening a window to the anterior chamber, peripheral iridotomy, reusable suture and conjunctival closure. For combined phacoemulsification, trabeculotomy surgery was done at the same session with 2 separate incisions, beginning with phacoemulsification, then trab surgery done after it. In the post-op period, 1 and 6 weeks, post-operatively we do the anterior and posterior segment examination, the axial length measured, as we said, by using IOL Master device. The statistical analysis is by IBM SPSS Statistical Version 21 program for Windows and by paired t-test comparing the axial length of the trabeculotomy and combined surgery preoperatively and 1 and 6 week post-op. Results. This table showing that combined patient were 34, as we said, with a percent 50.7. For trabeculotomy, we divide the group into 2 subgroups, phakic and pseudophakic. 21 from 33 patients were phakic and 12 were pseudophakic. For gender distribution, a male distribution were 61.2%, while female percent were 38.8%. This is the age distribution of with the types of surgery. This is the most important table for this study, showing preoperatively mean, post-op 1 week mean, post-op mean 6 week, and mean difference of the axial length and p-value. So for combined surgery, the mean axial length preoperatively were 23.2129 millimeter, reduced to 23.0623 millimeter after 1 week, and with the mean difference by minus 0.1506, and reduced to 23.0664 with a mean difference minus 0.1465 with a p-value is 0. For trabeculotomy faking subgroup, the mean axial length preoperatively were 24.4347 millimeter, reduced to 24.1657 millimeter after 1 week, with a mean difference is minus 0.2690, and post-operatively 6 week reduced to 24.2064, with a mean difference minus 0.2143 with a p-value is 0. For TRAP pseudophakic subgroup, the mean axial length were 24.0050, reduced to 23.8666 1 week post-operatively with a mean difference minus 0.1383, and reduced to post-operatively reduced to 23.9150 millimeter 6 week post-op with a mean difference minus 0.900 with p-value 0. So we see there is a decrement in the axial length post-operatively after 1 week and 6 week. We had previous studies for trabeculotomy that there was a statistically significant reduction in the axial length with a mean reduction of 0.423 millimeter, as mentioned in Cashwell and Martin et al. Study. In this study, the mean reduction is smaller. A possible explanation, we used the non-touch technique, LIOL master, while in previous study they used the A-scan ultrasonography, which is touch technique, induce more indentation and decrement in the axial length. A similar result to our study was proved by a study done by Shiniji Yusoi et al. Study. In Chakraborty et al. Study, an Indian person reported a direct relation between the IOP variation and axial length and an inverse relation with choroidal thickness. A possible explanation is due to edema and inflammation that may be happened after surgery and may be due to diurnal fluctuation in the choroidal thickness. This may lead to change in ocular dimension, as mentioned in a study done by Nemeth and Hirokzi study. Also, a possible explanation may be due to diurnal fluctuation of ocular blood flow, which may be higher in patients with primary open-angle glaucoma, and as we know that primary open-angle glaucoma is the most common type of glaucoma worldwide, as mentioned in PEM-B et al. Study. The optic nerve and choroidal blood flow had been shown to reduce in primary open-angle glaucoma. This means there is a vascular dysregulation, as mentioned in Fuchs-Jacker, Merrill, G. et al. Study. This vascular dysregulation accentuated by trabeculotomy and lead to increase in pulsatile ocular blood flow in standing position and lead to a postural difference and related to IOP. Another study done by Lee et al. Found that there is less posterior displacement, which means there is more anterior displacement of the lamina cribrosa and the thickening of it after a decrease in the IOP. From all of these reasons that are mentioned above, the axial length was reduced significantly. The importance of this decrement is that this caused a change in the refractive state of the eye postoperatively, as mentioned in Francis B.A. et al. Study. A similar result found in a study done by Law S.K. et al. For combined surgery, in which the axial length was significantly decreased postoperatively and correlated with postoperatively IOP. Limitation for this study, we have to mention it. that there were a small sample size, short follow-up period, and difficulties in attending the patient to the hospital for following up them. We have to recommend that the follow-up period must be extended to find if this change in axial length still progress or it will return to an equal or near equal axial length before these surgeries, and if there is any change in refractive state of those as a consequence of this axial length change. Conclusion: trabeculotomy and combined phacotrabeculotomy surgeries showed a statistically significant postoperatively surgically induced reduction in axial length, and thank you.
Thank you, Dr. Ahmed, to touch this very important subject, which is the relation between refractive errors and trabeculectomy. Thank you very much.